My name is Lois Donovan. I'm a clinical professor at the University of Calgary, and I specialize in the area of diabetes in pregnancy. I'm talking to you today about the use of time in range in pregnancy. So this graph here shows the recommendations from the International Consensus on Time in Range, and they differ in their thresholds from outside of pregnancy, such that the time in range that's recommended for pregnancy ranges from 63 to 140 milligrams per deciliter. Now, I'll talk about some of the robust evidence that we have for that in type 1 diabetes, but I also want to mention that in gestational and type 2 diabetes, there's limited evidence for time in range, and studies are currently ongoing that are looking at that. Because women with type 1 diabetes struggle more with hypoglycemia, it's often much more difficult for them to achieve a recommended 70% time in range in the second and third trimester. But it's important to remember, for those that cannot reach the recommended 70% time in range, that differences as small as 5 to 7% are associated with improved neonatal outcomes. So we'll just look at some of the robust evidence from type 1 diabetes from the CONCEPT trial. And this was a randomized controlled trial, randomizing women to continuous glucose monitoring in pregnancy or just capillary glucose monitoring. And in this trial, we saw small differences in hemoglobin A1C that were significant, but they were small, just 0.2%. But when we compare the time in range between those randomized to continuous glucose monitoring and those to capillary monitoring, we found that those using continuous glucose monitoring spent 100 more minutes a day in time in range, so 7% more time in range. And this seemingly relatively small difference in time in range was associated with improved neonatal outcomes, which I'll talk about on the next slide. But first, I just want to review that both pump and multiple daily injection users were shown to benefit from the use of CGM in pregnancy, and that the improved neonatal outcomes that we saw with CGM was attributed to reduced exposure to maternal hyperglycemia. And CONCEPT was the first trial to demonstrate benefit of continuous glucose monitoring on health outcomes beyond glucose control. Just to summarize those neonatal outcome improvements, we saw LGA still remained high in women with type 1 diabetes, but was reduced from almost 70% down to 53%, giving us a number needed to treat of only 6 women to reduce 1 case of LGA. Neonatal hypoglycemia requiring IV glucose therapy was reduced from close to 30% to 15%, with a number needed to treat of 8, and NICU admission greater than 24 hours was reduced from 43% to 27%, giving us a number needed to treat of 6. Thank you very much. I hope you find this information helpful as you care for your women with diabetes in pregnancy. For more information, please visit the American Diabetes Association Time in Range website at professional.diabetes.org/time in range.